And so we look for solutions that will help women and families, navigate these issues and improve their lives and help them improve health outcomes not only for themselves but for their families. And so health information technology for us is a key part of that. We see it as a key tool that men, women, and families, that everybody can use, not only to manage their own care, whether that's for themselves or for a loved one, but also to improve health outcomes. So to that extent, one of the things that we do a lot of is organizing the consumer voice around a lot of different healthcare issues, whether it's disparities or insurance market reform. But the Consumer Partnership for eHealth that Steve talked about is actually one of our most successful, broad, and influential coalitions. So that's really what I'm here to talk about today. We started the work sort of informally. A number of players came together in 04 and 05 talking about the impact of information technology on consumers. And at that time, the conversation was really about privacy, right? You had in Congress a piece of legislation that had come forward from Congresswoman Johnson that would have preempted many state privacy laws that are in fact stronger than the federal laws that we have today. And so that was where the conversation started. And it has evolved over time. CPEH has become a very influential and diverse voice for consumers, had a very lead role in shaping the HITECH provisions in ARA last year. And I can say that with a lot of objectivity because it wasn't me that actually led that work. It was Eva Powell and under Deven's leadership as well. So, but, having been on Capitol Hill when I was with EHI, we saw the influence and the work of CPEH, and it was really very impressive. But we started from where folks were and really evolved into a broader, focus, including privacy and looking to privacy as an enabler for building public trust and consumer engagement into some broader delivery system reform issues. And so the two pieces, did they get handed? They did. So the two pieces of paper that I wanted to share with you today are really about the paper. There's a two-pager, and we'll make this available electronically. There's a three-pager called Getting to Patient-Centered Care, How Health IT Can Meet the Needs of Patients and Their Families. This is our contribution to the meaningful use discussion. But we started not with the discussion about health IT, but with the discussion about patient-centered care and what that means. And so you can see on the left-hand side of that three-pager the work that we've done to define what patient-centered care is from a consumer perspective. On the right-hand side, we've then sort of adapted and analyzed what are the more patient-facing functions of technology that ought to be included in a definition of meaningful use. So the two slides that you have are sort of a summary of what I'd like to say today, and that is that we look at meaningful use in the context of how well it will engage consumers in improving their health status, in making their experience of care better, and helping them, in fact, reach their health goals. So from that, you can see that we think there are some key roles that information technology needs to play in the policy debate that we're having from the perspective of consumers. And so this is sort of the health system perspective that I wanted to share with you today. And you can see that information technology has a role for creating care that is comprehensive, it's individualized, that is planned and coordinated, of course. We focus a lot on shared decision-making and patient decision support, how we can use information to facilitate safe and effective transitions of care, ensuring broader access to care. And we define access in a pretty comprehensive manner, and that's everything from after hours or non-traditional access through secure messaging, for example, to making sure that we're giving patients access in the language that matters most, and that is their preferred language. And then finally, looking at how we can use information and information technology to assess and improve both the quality and the experience of care, including the reduction in disparities. So with that, if that's all right, I'll go ahead and hand it over back to Steve.
Thanks, Christine. Deven?
Christine, can you hand me the little slide thing? I think it's that thing that looks like a cell phone, but it's not. I don't think. Okay, great. So, Christine, you stole my line, privacy as an enabler, but I'm really glad to hear that, actually.
Great.
We secretly conspired. Thanks for allowing me the opportunity to talk with all of you. I've met many of you through the many years of working on this issue, and so I'm really delighted to be here. This is a great group of people. So what do I mean when I say privacy is an enabler? Well, we know that the public wants health IT. There's lots and lots of survey data out there, but we also know that people get nervous when they think about the prospect of having their medical records be online or in electronic or some sort of digital format. So the key is actually to build privacy into the system and not to see it as the obstacle and the difficult hurdle that if we could avoid it, we would love to do that, but instead to see it as an enabler. And really the true impediment would be the failure to enact appropriate and workable privacy and security solutions. Now, there's some survey data that's coming out more recently that indicates that patients are willing to trade off some privacy in order to get more health information exchange. And I don't necessarily disagree with that, but I think it depends on how you define privacy, because if you define privacy in a way that means the information's in a little box somewhere that's encrypted and very secure and never goes anywhere, well then of course, because patients actually do want the information to be shared among their healthcare providers, they do want it to be used for the most part for public health and quality improvement activities, then that to me isn't privacy. Privacy and confidentiality are the set of solutions that you put into place that enable information to be shared for the right reasons, but that foreclose inappropriate access to this information, because we all know that as we make this information more available for good uses, we also inadvertently make it potentially more available for uses that the consumer would not be quite so happy about if they knew. So, I've given this talk a lot, and so I'm going to skim through this. So what do we mean when we say the next generation of health privacy? HIPAA was the first generation. That was really more than 5 years since the regulations were implemented, and most of the meat of privacy and security is really in those regulations. But the world has changed really in those 5 years, and we're foreseeing more rapid changes. And in fact, we're sitting here this morning wondering how we can do it better and faster and make sure that it actually gets done. So what does it take to do this? Well, number one is there's no one-size-fits-all solution to this. If the privacy policies fit with the information flows that we want to generate, then those policies are going to look different when we impose them on health information exchanges or for healthcare system entities than what we're talking about for a personal health record that is intended for the consumer to use. Obviously core privacy principles based on fair information practices have to come into play, but the way that we design these networks also plays a role. Similarly, there needs to be adequate oversight and accountability for all of this. And again, we frequently look to the Markle Foundation's Connecting for Health Common Framework, both the one with respect to exchange of data by healthcare entities as well as the one for networked personal health information, which is directed at personal health records and other access tools. So you fill the gaps in HIPAA for the healthcare entities, and then you look to where now we have data that's migrating out of the health system is being held by entities like Google and Microsoft, Revolution Health, WebMD, insert name here. It's ever expanding, it's ever innovating. Do the rules that fit for healthcare systems make sense for those entities? We posit that they do not, at least as a whole. There may be pieces of it that make sense to apply, but nevertheless, we have to think about those things. So we're in a better place than we were a few months ago. That's in my view, depending on who you ask. I recognize that there are a lot of stakeholders that are quite nervous about the privacy provisions that were adopted in the stimulus legislation. They included improved enforcement, extension of HIPAA coverage to electronic exchanges through business associate relationships, tightening the rules on use of information for marketing, setting in place a process for examining the HIPAA standards for de-identified data, and then ensuring that consumers can electronically get a copy. It says electronic access on my slide. The actual wording is electronic copy of a record when there is an electronic health record actually being used. So we made a big leap forward in our view, but there's still, I think, a lot of work to be done. Number one, which I didn't put on the slide, but which I'm sure is obvious to all of you who work in healthcare systems, is that we have a tremendous amount of work to do in implementing these statutory provisions, and a lot of questions have been raised, and I don't take the criticisms and concerns that have been brought to my attention lately. I actually really do want these things to work and to find a way through the regulatory and guidance process to make them work. Establishing a culture of privacy, I still think we think that when we enact laws, we've taken care of privacy and we don't have to think about it anymore, when in fact it's a question that should come up every time we think about building a health information exchange or new ways to exchange data. That should always those conversations should always take place with conversations about, okay, well, how do we protect the privacy, confidentiality, and security of that data? What are both the policies and the technical solutions that need to be put into place so that patients trust the system and we also achieve the information flows that we want to achieve? That's harder to do through a piece of legislation, and is something, that I know that in my work I'm constantly faced with, this notion that, well, we did that already and we don't have to think about that anymore. We maybe don't have to think about it in a piece of legislation every year. I wouldn't necessarily advocate for that. I feel like I just ate a really big meal with all the stuff that's on our plate now in terms of implementing it. There's a lot of work to do. I think the other nut that we haven't quite cracked is, again, when this information flows out of the healthcare system and is being maintained by companies that are not covered by federal health privacy laws like HIPAA, what are we going to do about this? And to some extent, those questions weren't as solidly answered in the economic stimulus legislation as was the case for many other of the gaps in HIPAA. One being, we have this notion of when a PHR vendor might be covered under HIPAA as a business associate because of a relationship or partnership that takes place, such as between a hospital and Google Health or Microsoft Health Vault. There's a lot of open questions about when that occurs. I have ongoing concerns, again, about the way that HIPAA is structured, which allows for data to be accessed, used, and disclosed for treatment, payment, and healthcare operations without the patient's consent, and whether that infrastructure makes any sense at all for a product that we hope that consumers will use and control more than they do with the record in their healthcare system, records held by healthcare system entities. And then with respect to downstream recipients, so let's say we get Microsoft and Google covered, but the real value in those PHRs is when they're used as platforms and not just shoeboxes of records. Not that there's isn't necessarily inherent value in that, but I think we know certainly the business model of these products is built on the use of what are called third-party applications, the diabetes management service that I can take advantage of because I have an account with Google, Microsoft, insert company here. And those downstream recipients, again, we have the same downstream problem with PHRs potentially that we've always had, or that we have historically had with HIPAA, and maybe not so much anymore, where we have entities that are covered, but once the data starts to migrate out and down the chain, the protections are less. And then the third one I'll mention is encouraging greater use of what I'll call anonymized data, because I know I can't say anonymous because there really isn't a such thing as anonymous, truly anonymous, for public reporting, quality improvement, and research. Right now we have some data sets under HIPAA that can be used for these purposes. Fully identifiable data is allowed to be used for a lot of these purposes. But it doesn't necessarily need to be used for those purposes. We have a limited data set which requires the stripping out of certain data points, which is allowed to be used for some purposes, but isn't always so helpful because it mandates the specific removal of certain data points, which sometimes makes it unusable for the very purpose for which you want to use it. And then on de-identified data, again, even more data has to be stripped out, at least under the safe harbor method that most people use. And again, that sometimes renders it not useful. But also, then when it qualifies as de-identified data, all bets are off under HIPAA. It's not protected at all.